Good morning. Thank you to the chairs here and to SAGES and to all of you who are spending your Saturday morning with us. I have no disclosures. So when to operate? Decisions, 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 right? So we could do it now, or should we do it in less than 72 hours, less than 5 days, less than 7 days? 4 to 6 weeks, or as mentioned, maybe never. And how do we make these decisions? The selection and timing of definitive therapy is going to depend on several factors, and they've sort of been alluded to in our prior talks, which is basically the severity of the disease and the comorbidities and severity of the medical risk. I think in the low-risk patients with very severe disease, it's fairly straightforward. In general, you're going to operate on them as soon as you can after resuscitation. But what about the less severe disease patients who are medically fit? Despite a bunch of literature which goes back to the pre-lap chole era, suggesting that early cholecystectomy, as defined as less than 7 days of onset, actually confers some advantages. There's been a persistence of practice of giving these patients antibiotic treatment, quote, cooling them off, unquote, and then coming back 4 to 6 weeks later. So the most recent Cochrane review, 2012, showed no particular difference between strategies, and you can either take that as equivalence or non-inferiority, or support either contention. The problem with that is that with their extreme vetting, the Cochrane series has 244 patients in each arm. So if you're looking for significant differences in the things that are important, like death, major bile duct injury, et cetera, that study is really not powered to answer the question. So do we have anything that's more recent with a few more patients, and can we get any information? So this is a meta-analysis from about 2015. There are 1,500 patients, which is a substantially larger number. Early cholecystectomy is defined as less than 7 days, is basically had lower wound infection rates, a shorter hospital stay, many less work days lost, slightly increased operative time of probably not a great deal of significance, but no difference in mortality, duct injury, conversions, or complications. Again, this may well be an underpowered study for very important endpoints which are relatively rare. So what are we going to do? Big data, right? The answer to everything now. This is a study from Sweden. It's registry data. They define early cholecystectomy as anything less than or equal to less than 5 days. Looking at several endpoints. One of them is intraoperative events, right there. Post-op adverse events is here, and conversion rate is the dark. And as you can see, as time goes on, these events increase in general. Very important to look at, however, also is how many patients are in each group. The Swedes are advocates of early operation. So some of them are sicker, and they're going to be operated on right away. But in general, they're operating within 2 days or so, these numbers here. And we're going to compare that to the group that's at greater than 5 days, which also includes up to the 4 to 6 week line. But that's only 5% of the patients. So we have a problem potentially with these data, but at least they're at least suggestive of that it may be at least safe and to operate early, and that we're not incurring extra risk because of the situation. So these are some of the data as multivariate analysis here, looking at intraoperative, looking at intraoperative events. Here, showing statistically significant differences between early operations and patients who are greater than 5 days. Intraoperative bleeding, there was no difference. Interestingly, bile duct injury was seen to be lower in patients who were operated on immediately. I'm not sure exactly what to do with that, especially when you have so many different variables that you're looking at. Postoperative adverse events are much higher in the group where we have delayed operation. Mortality is really, I would say, not statistically significant. But 90-day mortality, there seems to be a suggestion that it's may be somewhat improved in patients who are operated on early. So with that caveat, so how do we then decide whether or not those small group of patients who were operated on early, operated on late, whether that's of any significance or not? So our nice friends from the north, the Canadians, looked at their data, and they did a propensity score analysis trying to make those groups as homogeneous as possible with very close matching. And their primary endpoint was major bile duct injury, with the secondary endpoints of a combined bile duct injury or death, as well as looking at mortality, conversions, etc. So what did they find? They find that there was a higher incidence of bile duct injury in patients who were in the matched cohort here with delayed cholecystectomy. Their secondary endpoint as well was higher in patients who had delayed surgery. There was no significant difference in the matched groups as far as mortality or cases completed open or conversion. So the next question, I think, is 72 hours the magic number? After your patients have been marinating for 72 hours with their symptoms, the observation has been that our inflammatory cholecystitis now becomes possibly more of an infectious situation, and that we have fibrosis and other changes which make your operation more difficult. So this is a small study from the Swiss, but it is randomized, and it takes away some of that bias of illness, looking at several things. I think the endpoints here are overall morbidity, which is higher in patients with a delayed operation. These are randomized to either getting quote, early cholecystectomy when your symptoms are over 72 hours, or waiting for 4 to 6 weeks. So we had a significant difference. We had a significant difference here in overall morbidity, and this is really driven by unplanned readmissions and problems in patients who were given antibiotics and then sent home, and then they come back and they bounce. The antibiotic duration was also significantly different. Total hospital stay and also cost was higher in the patients who were randomized to delayed surgery. Other interesting things, a number of other things were not particularly different, especially operative time and postoperative complications, etc. Interestingly, if you look at the pathological diagnosis up here, we're trading, with the early one, we're trading a preponderance of early cholecystitis, or maybe with a little chronic cholecystitis, to the patients in delayed group, where we're looking at a high number with these pathological chronic cholecystitis, and I think we've all been in that situation where we're trying to chip a gallbladder away that's been sitting around for 4 to 6 weeks. No significant differences in conversion rates or other things that, again, this is a very small study, but I think it does give us some guidance. So generally, waiting the 4 to 6 weeks is sort of like our government trying to just kick the can down the road, hoping that it's just going to go away, but you will have to pay the piper at some point in time. So high-risk patients, I think antibiotics alone is okay, especially in the less severe cases. There is cholecystostomy, which we had a very nice and thorough discussion about a few minutes ago. Then the endoscopic approach, which we also heard about. One of the options here for an endoscopic approach is either the nasobiliary drain or actually the Axios stent. This is, of course, a slide from one of my GI colleagues as we're looking at what's invasive and what's non-invasive. It's not invasive to drive a scope through and try and put a hole between two structures, and that's not invasive. That's fine. Okay, I got it. But it can be very useful. This is a patient who with metastatic pancreatic cancer who had a porta which was socked in with disease, a CBD stent, then leading to acute cholecystitis. And this is the stent between the stomach and the gallbladder with laudable pus coming out. And that patient is fine now 7 months afterwards on chemotherapy, but no biliary symptoms. This is an elderly woman with about every comorbidity you could ever ask for. No organ system has been spared, basically, who has calculus disease. And one of the things here is not only is the gallbladder being drained, but also you can clear the gallbladder of some of that stone burden. And this is basically her permanent solution, not a bridge. Every once in a while, you're stuck. That you get that patient who you just do not want to operate on, but guess what? You don't have a big choice. So here's an example. Okay, we have emphysematous cholecystitis. Not too subtle. What's this? Well, that's the drive line to the LVAD. And you are stuck. And this is a case where actually we did operate on this patient. The cardiologists were on board, everybody was on board. They were about as stable as they're ever going to get. And we don't want to have overwhelming sepsis and or positive blood cultures with this little bit of hardware that's sitting here. Patient had a successful laparoscopic cholecystectomy as far as those symptoms are concerned. Did succumb several months later from their heart disease, but this particular time we were able to do something at least to prolong the situation. So every once in a while you do have to just hunker down. So this is up to date. Similar things to what you've seen from the Tokyo guidelines. With acute cholecystitis, admit them, let them sort themselves out. Surgical risk, low risk. They're doing better, take the gallbladder out. They get worse, cholecystostomy. Higher risk patients, they're improving, you discharge them, and then you may figure out whether or not this was acalculous and maybe they don't need anything, if their cholangiogram is okay, or maybe they will get a cholecystectomy at some point in time, but that's something that you can sort out later. And obviously, if they're not doing well and deteriorating, that the cholecystostomy is a reasonable approach. So what I would say is I would take something from the John Keating playbook, which is, when you can, seize the day. Thank you very much for your attention.